Hello, we are here to go over our 2020 updates to our EMS guidelines. And of course, like everything else, this is happening in a distance format, but I think that should be fine for the material that we're covering today. We do not, fortunately, have to make major updates to our guidelines. They're already in pretty good shape, but there are a few small changes we'd like to make. Probably the most noticeable thing with the guideline update for you is the actual appearance and formatting. That is being spearheaded by Carlos, and hopefully that will be more usable for people, and we can certainly take the feedback on that. All right, so let's just jump into the actual content update for 2020. We are not putting the content changes into effect until everybody has been through training. Starting with trauma. Not much has changed in the world of trauma, with the exception perhaps of a little bit in the area of burn care. So those who have been around EMS for a while may remember when there were cool dressings for all patients with burns, moist dressings. And then there was all this concern about patients becoming hypothermic, and so we backed off for larger burns to using dry dressings for everyone. And now there's a remarkable amount of evidence, because we know everything goes full circle, that patients that get their burns cooled actually have substantially less need for skin grafting. And there's actually quite a few studies on this. This is actually out of the Journal on Burns, pretty exciting reading. And they defined adequate, and this was a Australian study, and so first aid is, really they're talking about pre-hospital care. Adequate first aid was defined as the application of 20 minutes of cool running tap water up to 3 hours following the burn injury. And they had about 400 patients, and they looked at the patients that had that compared to the patients who did not. And patients who had this cooling of their burns had a significantly lower amount of need for skin grafting. And the interesting part of this is for large body surface burns. And so this has been looked at in small burns. This has been looked at in large burns. This is not, we're no longer a burn center, at least right now at UNM. And so we are transferring out large burns. Hope that we'll be a burn center again in the near future, but for now, large burns are being transferred out. I can't guarantee you that all the doctors that are receiving these patients are going to have heard all the same education, but at least want you to consider, when possible, trying to cool these burns. I'm not suggesting that patients with, large body surface area burns, you're gonna, sit on scene and try to find tap water to run over them. But if there is the possibility of cooling off the burns, putting some moist dressings on, that is appropriate now. That is really the only change in the world of trauma as it affects our guidelines. Jump ahead to adult cardiac. And the beauty of this format is I don't have to stop for questions as we go. Okay, this is probably the one that pains me the most. So we're going to talk a little bit about STEMI care, and I continue to think that we do a fantastic job, or you all do a fantastic job of taking care of these patients. We are still going to emphasize keeping the oxygen kind of in that 94-ish range and not giving indiscriminate oxygen for all of these patients. And from reading charts, it seems like people are doing a great job of titrating oxygen and not putting it on if they don't need it. Some of you may be aware that Albuquerque Bernalillo County actually took nitro completely out for the care of STEMI patients. And we, in talking with the receiving cardiologists at all three centers, would still like to see nitro left in the guidelines as an option. And I think everybody has really embraced this already. It's if the patient has a good blood pressure, not a marginal blood pressure, but a good blood pressure, and there's no evidence of a right-sided MI. So that's not just an inferior MI. So for the medics, you have to be able to, if you see evidence of an inferior MI, then you should be getting right-sided leads. If you see, you should do that regardless. If you see no evidence of a right-sided MI, then you can consider a single dose of nitro. And if they have a good response in terms of symptom relief without adverse effects, then you could consider giving them another one. That's not a change. I'm just re-emphasizing that we talked about it. We saw what Albuquerque was doing. We talked to the cardiologist and decided to leave this as it is. And I think everybody has been really good about doing that. Now, here's the hard part. After all of the training we've done on folks on remote ischemic conditioning, we're going to take that away. And why are we doing that? Well, there was a lot of literature out there, but all small studies. Some were pre-hospital and aeromedical that were showing benefit, enough so that a group in Europe decided to do a multi-center trial over 5 years and enrolled over 5,000 patients into a randomized trial. So there was enough evidence to justify the trial, which is why we were continuing to do this, but not enough evidence to know that it was beneficial. There was no evidence of harm, which was also the reason we were continuing to do this. But when they actually did the really big study that we'd been waiting on, there was no evidence of improved outcomes. Still no evidence of harm, and it doesn't cost anything. So we had a very interesting conversation with the the chiefs of interventional cardiology at the 3 health systems. But in the end, and there was actually some mixed opinions among that group, but in the end decided that evidence-based medicine would prevail, and without the evidence, we're going to go ahead and stop doing that. So again, another example, the longer you're in this business, the more you'll see things come and go. So my apologies for that one. Cardiac arrest, not a lot of changes here. Already doing a great job. We're going to emphasize whenever possible, this is BLS and ALS, starting with an anterior-posterior pad placement, as opposed to the traditional anterior and lateral pad placement. That traditional pad placement was never based on what was best for delivering energy to the heart. It was based on what was easiest for in often cases, a single provider with an AED and a potentially large patient, not being able to roll them to get the pads posterior and not wanting to delay a shock. When we have the resources, it's great to go anterior posterior. This is how patients are cardioverted in the electrophysiology lab, for example, because they know that that's the best way of delivering energy through the heart. Now, if you are in a situation where you're a crew, you're a one-person command staff, for example, and you have an AED and you show up at a cardiac arrest, or a law enforcement officer by themselves, we don't expect you to try to do anterior posterior. But as soon as possible, even from the first shock, if it works, go anterior posterior. We are still avoiding multiple intubation attempts. And since many of you will be I don't know when everybody's going to be watching this, but this is in the era of coronavirus. So I will at the end talk a little bit about some other specific things for cardiac arrest. But avoiding multiple intubation attempts, we're already doing that. One attempt with CPR in progress is the traditional. Now in the era of coronavirus, it's one attempt without CPR in progress is an option, or we move, as we usually do, straight to an extraglottic device. Still emphasizing early epinephrine as early as possible, and we're still happy with our every 10 minutes. There's literature all over the place on this, but looking at the experience across the metro area, we certainly have not seen any harm from going from 5 to 10 minutes, and a lot of evidence out there that would suggest that that's beneficial. As far as double or dual sequential, not simultaneous, shocks, There's more and more research coming out on this topic. At this point, my read on the literature and talking to people that are doing these investigations at national meetings, it's reasonable to still keep it in our guidelines, but we're not yet ready to move it up earlier in the algorithm. So we would go to double sequential only after we've made 4 attempts at traditional shocks, including at least 2 in the anterior-posterior orientation. So if somebody gets there first, puts on an AED, and they're doing anterior lateral, other people, resources get there, we move the pads, anterior-posterior. If 2 of those shocks, we still have refractory VFib or VTAC, we can consider double sequential. In my anecdotal experience, I've had great luck converting people, but I'm usually converting them into a systole, which is not necessarily very helpful. On the other hand, if somebody has not responded to 4 shocks, we can imagine that there's a reason, and we're going to have to try maybe something desperate, which is why we still have it in place, and very interested to see what other research will show on this. So that is likely to change. Whether it goes away based on the evidence or it gets moved up earlier in the algorithm remains to be seen. All right, CHF. The only change here is that based on state scope of practice changes, we'll be moving nitro into the AEMT level for congestive heart failure. It was previously nitro for presumed cardiac chest pain only. And I've been pushing at the state level for this change for a while. And we know our AEMTs are doing more and more transporting, so it's good to have that option there. The other thing is that we're going to increase the nitro dosing for CHF specifically. So this is not for STEMI. For patients that have a systolic blood pressure over 200, which is not uncommon with flash pulmonary edema, to 2 simultaneous tabs or sprays as opposed to just 1. So this goes from 0.4 milligrams to 0.8 basically, okay? This is like 800 micrograms of a dose. There is a study recently that looked at intravenous nitro for EMS, and they found safety with that. This reflects my practice when I was a resident 20 years ago. This is what we were doing, and I think there's some more evidence that we are not dropping blood pressures on these kind of patients, and this is has a potential for benefit. So small change. We don't see a ton of these kind of pulmonary edema patients, but if this is in the setting of a STEMI with pulmonary edema, then that's cardiogenic shock, and those patients usually do not have a good blood pressure. In fact, they may have a terrible blood pressure, so we probably won't be giving them any nitro. CPAP remains our friend for CHF. Dysrhythmias. Not much changing in treatment, but there is a little conceptual change in our terminology. We have traditionally divided patients in our guidelines into 3 groups. We had patients that were sort of in the stable, unstable, and this middle ground of symptomatic, and decided that perhaps that was confusing and made for some complicated algorithms. So we're going back to stable and unstable, matching what is always been sort of the case in the American Heart Association guidelines, and then allowing people to use, as we always do, their judgment, and to, not all unstable patients or stable patients are the same. And so it's not going to change the treatment options that are available. It just maybe simplifies the guidelines. Post-ROSC care, again, right now we have obviously a lot of ALS topics. We have moved away, so those who've been around here for a while, remember when we were doing dopamine drips as our pressor, and did not see a lot of people starting those drips because things were busy. It was a little cumbersome, which is why we went to the Epi Mini Bolus, which has actually worked out quite well. And I think we can see lots more patients getting appropriate pressors as a result. But we've also had some cases where people are giving or having to give a ridiculous number of these mini boluses and become a human infusion pump. And so we're going to give the option of an epinephrine drip. You can still give them mini boluses if that's quicker, or you feel like they just need a few doses. That's totally appropriate. All right, that's it for cardiac care. Adult medical. Not a lot changing here. The one change is for patients with presumed hypothermic cardiac arrest. We would like those patients transported to an eCPR ECMO center. We generally do not look to transport patients from Rio Rancho for ECMO in the setting of cardiac arrest, what's called eCPR, because of our time distances and the need for those patients to get to hospitals fairly quickly. This is an exception. Right now, UNM is the consistent eCPR center. Press Downtown has recently come online, but then sort of like a lot of places because of coronavirus come offline. And so I can't guarantee you that this is always going to be available until we get through this current crisis. And then I also suspect Loveless at some point will come online to be able to provide eCPR. The point of this is there have been some amazing outcomes reported in the literature, and we have also had some amazing outcomes anecdotally at UNM of patients that were profoundly hypothermic, put on ECMO, warmed up. We can warm these patients on ECMO unbelievably fast, and we've had some patients that literally asked for their cannulas to be taken out the next day and signed themselves out of the hospital completely neurologically intact. So that would be appropriate, even with our added transport times, to take these patients downtown. And we've always said they're not dead until they're warm and dead, but then we've made exceptions for patients who seem like they're really stiff and have been outside for an unknown amount of time. I think the threshold has changed, and we're going to transport more of these patients if there's any question at all. We have seen reports of young patients who were found outside, unknown duration of time, were felt to be stiff, and had good neurologic outcomes. All right, big change, going from cardiac arrest to nausea, and the addition of isopropyl alcohol aromatherapy. And you know, that aromatherapy sounds like we're opening a Pandora's box, and we're going to have all these little vials of various essential oils to give patients and dab on their temples, and who knows, maybe that will come. But it sounds much less like a medication when you call it aromatherapy, and that's how it was presented to the Medical Direction Committee, and they agreed that this did not require a scope of practice change to formularies. It didn't require a special skill, which was our fear. And if you haven't heard about this, this is remarkably effective. There is literature on this and a lot of anecdotal experience on taking a simple isopropyl alcohol wipe, opening that, and having the patient sniff that for nausea, the mechanism of which has not yet been determined. I can tell you that at Lifeguard, our rotor pilots love this. They often have family members sitting up front in the aircraft, and I can remember at least one bumpy flight on a warm day back from Roswell where the pilot just kept tapping me on the shoulder and saying, hey, I need another alcohol pad, and for the family member that was up front, and we just kept handing them up there every 10-15 minutes, and the patient made it through the trip without vomiting. So very anecdotal, certainly something you can also use in your personal life. If you have these in your first aid kit, this can be very handy. So that will appear now in our guidelines. And that should be at all levels of care as well. Anaphylaxis, not much changing here, except we will consider epi-drip, just like we said for post-cardiac arrest. Some people who are really up on the literature may be aware that there's been some discussion, and it's been on some of the EMS blogs, about a study showing steroids to not be helpful in anaphylaxis. Have chosen not, based on one study, to pull that out of our guidelines. Airway, not much changing here. There's been some interesting discussions about PEEP, particularly in our post-cardiac arrest patients, that we probably shouldn't be using PEEP on those patients. But when you get ROSC, totally appropriate to add in a little bit of PEEP. We've already been using that, and I would encourage people to put PEEP on a PEEP valve on any time we're doing bag mask ventilation, unless the patient has a good SAT. Most of the time we're doing bag mask ventilation, they don't have a good SAT. PEEP is really the key to opening up the small alveoli where gas exchange is happening. And the PEEP valves come with the ventilator, so you can take that same PEEP valve and off the vent circuit and put it on the exhalation port of a bag and do a much better job of mask ventilation. We are also exploring a special skill for medication-facilitated airway management. That certainly got pushed off a little bit in light of COVID-19 concerns, but that is sort of coming, we hope. The epi mini bolus or drip option is also going to appear for septic shock patients. So pretty much anytime we're giving somebody a pressor and giving mini dose epi, we could also consider an epi drip now. That's it in the medical emergencies world. OBGYN, hang on to your seats. Okay, that was it for changes in OBGYN. Pediatric medical. Yep, that was the same. Not anything changing there. Pediatric cardiac, the only change here is that if we're going to terminate cardiac arrest in a pediatric patient, we would want a phone call, and we would want a phone call to the consortium, not to another MSEP. I hope that we're not going to start seeing more of these than we're seeing, and it is most people's practice anyway to want to engage somebody in that decision, but these are challenging circumstances. It used to be that pediatric arrest got transported just all the time. And now, as we've really changed our focus across the metro area and nationally to mirror more of what we do with adults, which is stay and start a good resuscitation, make sure you're doing good airway management, get your access, get your epi, make sure you're doing good basics. We're finding that there's more patients for whom transport may not be appropriate, and if that's the case, please give us a call. I have absolutely, and most of the consortium docs now have terminated cardiac arrests in pediatric patients on scene, unfortunately, but it is happening. Most of these, I think, are more often than not drowning cases. All right, formulary. Let's see, we talked about nitro, dose going up only for CHF and only if, suspected CHF, and only if the systolic blood pressure is over 200, and that we're also mirroring state scope and adding nitro for AEMTs for CHF. We've talked about the epi-drip option. One other change is, and some people have been aware of this, something I've done in my practice for a long time, but more evidence that it is not only safe, but and effective, but potentially more effective if you combine, instead of the traditional, and I think everybody, I'm sure even the basics have probably at some point seen adenosine pushed. If you haven't, this is the medication that we're giving for patients that have an SVT, supraventricular tachycardia, that are not so unstable as to require cardioversion, but not so asymptomatic as to need nothing. And so the traditional treatment is adenosine intravenous, but this medicine, once it comes out of the vial, has an incredibly short half-life. And you have to get it to the heart before you lose that half-life. So traditionally, we will use the largest proximal IV that we can, an AC ideally, and we will put the adenosine in one syringe. We put a flush attached to a three-way stopcock if it's available, and we will give the adenosine and follow it, turn the stopcock and give the saline as fast as we can to try to flush that into the system and get it to the heart. We will, if a stopcock is not available, then you have to, as soon as you push the adenosine, unless you have a two-port option, which sometimes people will use an upstream attachment. Sometimes we'll see people taking the syringe off, attaching the saline flush, and giving that as fast as they can, or squeezing the bag. Not very effective. So the option is to just dilute the adenosine in a syringe and give that whole syringe all at once, the one syringe option. So it's not really that it's taking the adenosine out of the vial that's deactivating it. It's once it gets into the bloodstream that its half-life is very short. So this seems to be effective, and so we're giving that to you as an option. And then the other formulary issue we talked about was the isopropyl alcohol. So that's really it for our guideline updates for 2020. Nothing, nothing earth-shattering, hopefully, for folks that's going to change too much of your day-to-day practice.